Welcome to this board review deep dive. Today, we're really focusing on suture materials and needles. Essential stuff.
Absolutely. Understanding these is fundamental for any surgical resident. It directly impacts outcomes.
Right. Our goal here is to cover the key properties you absolutely need to know for practice and, of course, for your exams.
Precisely. We'll break down everything from absorbability to needle configuration.
Okay, let's jump right in. Absorbable versus non-absorbable. What's the core distinction we need to grasp?
Well, the main thing is duration. Absorbable sutures lose most of their strength, say at least half within about 4 weeks, and eventually they're gone completely.
Gone completely. How does that happen?
Two main ways. Synthetic absorbables break down through hydrolysis. That's a reaction with water. It tends to cause very little inflammation, which is good.
Okay, hydrolysis for synthetics. What about the others?
The natural ones, like gut suture, they degrade via proteolysis. Enzymes break them down.
Hmm.
This process, though, it can cause more inflammation, maybe more scarring.
Mm-hmm. And the non-absorbables?
They stick around. The body reacts, walls them off, basically encapsulates them with fibrous tissue. They provide permanent support. So think disappear versus stay put.
Clear distinction. Now let's talk about how they're actually made. Monofilament versus multifilament, what are the practical implications?
Okay, so monofilament is a single, smooth strand. Think fishing line. It glides through tissue easily, less friction, and, crucially, less chance for bacteria to hide in crevices.
So, lower infection risk.
Generally, yes. Multifilament sutures, on the other hand, are braided or twisted like a rope. They tend to be stronger, more pliable, and hold knots better initially.
But the downside?
That braided structure can potentially harbor bacteria, increases the infection risk, especially in contaminated fields. Oh, and gut, even though it's natural absorbable, it behaves more like a monofilament in tissue passage.
Interesting. So trade-offs there. What about barbed sutures? They seem to be popping up more.
Right, barbed sutures, they have these little projections along their length. The idea is they grip the tissue, distributing tension without needing knots for certain closures.
Faster closure then.
Potentially faster, yeah. But you can't really back them out easily if you need to adjust, and they could snag tissue or other materials. Strength-wise, they're pretty similar to non-barbed.
And they come in both types, absorbable and non?
Yep, both absorbable and non-absorbable versions are available.
Okay. Knot security is obviously critical. How do we define that properly?
Knot security is simply the force required to make a tied knot slip. It's all about friction and elasticity.
Friction and elasticity. How so?
Higher friction generally means better knot security. Braided sutures, with their rougher surface, usually have better knot security than smooth monofilaments. Elasticity plays a role too.
So with better security, you need fewer throws for a reliable knot.
Exactly. Fewer throws mean less foreign material, which is generally better for healing.
Let's talk more about elasticity. You mentioned it affects knot security, but what about in the wound itself?
Elasticity is the suture's ability to stretch under tension and then return to its original length. This is really valuable in wounds that might swell, edematous tissues.
Why is that so important?
Because an elastic suture can stretch with the swelling, maintaining tension without cutting through the tissue.
Mm-hmm.
An inelastic suture, like, say, stainless steel, doesn't give. If the tissue swells against it, it can act like a wire cutting through cheese.
Ouch. Okay, so elasticity is definitely your friend in potentially swollen areas.
Definitely.
What about memory? It sounds like something psychological, but what does it mean for a suture?
Yeah. Memory is the suture's tendency to spring back to its package shape, like being coiled up. High memory makes a suture stiff, harder to handle.
And that affects knot tying?
Absolutely. A suture with high memory doesn't want to lay flat, it fights you, and that can seriously compromise how well your knot holds. Lower knot security.
Got it. Now, fluid absorption and capillarity sounds related to infection risk again.
It is. Fluid absorption is just how much fluid the material soaks up. Capillarity is the tendency for fluid to travel along the suture, like a wick.
And why is wicking bad?
Because if bacteria get onto the suture, high capillarity can draw them along the suture track, potentially deeper into the wound. It's strongly linked to increased infection risk.
Multifilament's worse for this.
Generally, yes. Their braided structure provides more pathways for fluid wicking compared to smooth monofilaments.
Okay, let's touch on cost briefly. Is it a major factor?
It can be. The cost includes both the suture material itself and, importantly, the needle it's attached to.
Ah, so the needle matters cost-wise.
Definitely. Sutures swaged onto high precision, specialized needles tend to cost more.
Makes sense. And visibility, how do we make sure we can see the suture during surgery?
Often sutures are dyed blue, violet, green, just to make them stand out against tissues. Helps with placement and later removal.
Any downside to dyes?
Well, if you bury a dyed suture close to the skin surface, especially in thin skin, the color might be visible, which isn't ideal cosmetically.
Are some naturally more visible?
Braided sutures tend to become quite visible once they soak up a bit of blood.
Right.
Let's tackle suture sizing. The USP rating system. It's not straightforward diameter, is it?
No, it's not. The USP rating, those hashtag zero numbers like 30, 40, 50, they actually relate to the tensile strength needed to break the suture, not its physical width.
So a 30 gut might be physically different from a 30 nylon.
Exactly. They'll have similar breaking strengths according to the USB standard, but their actual diameters can vary quite a bit depending on the material. Think strength first, not just physical size.
Good clarification.
Hmm.
Okay, shifting to needles. Point configuration first. Cutting versus taper.
Right. Cutting needles have sharp edges specifically designed to penetrate tough tissues like skin or dense dermis.
Are there different kinds of cutting needles?
Yes. Conventional cutting needles have the sharp cutting edge on the inner curve. Reverse cutting needles have it on the outer curve.
Which is better?
For skin closure, reverse cutting is generally preferred. Placing the cutting edge on the outer curve makes it less likely that the suture will tear through the tissue edge when tension is applied. The inner curve placement can create a weak spot. Okay, reverse cutting for skin. What about taper needles?
Taper needles have a sharp point, but the body of the needle is round and smooth without cutting edges. They spread or dilate tissue rather than cutting it.
So less trauma.
Exactly. Less trauma, less risk of the suture cutting through delicate tissue. They're ideal for things like fascia, muscle, peritoneum, bowel, tendon tissues you don't want to slice unnecessarily.
Makes sense. Needles also come in different sizes and shapes. What do we need to know there?
Key aspects are curvature, like 1/4, 3/8, 1/2 circle. 3/8 is very common in plastics. Needle length is the distance along that curve. Cord length is the straight line from the point to the swedged end.
And diameter.
Needle diameter, yeah, the thickness. It's a balance between needing enough strength to avoid bending or breaking, but being as fine as possible to minimize the hole it makes.
And those codes like PPS or SH,
Those are vendor-specific codes, yeah. They represent combinations of needle type, size, curvature, etc. You sort of learn the common ones for your specialty. PPS often means plastic surgery cutting needle. SH usually means small half-circle taper.
Okay, let's synthesize this. Choosing the suture. Absorbable versus non-absorbable. How do you decide in practice?
It depends on how long you need the suture to provide support. For closures under minimal tension, like maybe skin or mucosa where you've got deep support already, a rapidly absorbing suture like plain gut might do.
And for more support.
If you need strength for, say, 4 to 6 weeks while the tissue heals, think fascia, subcutaneous layers, then an intermediate absorbable like Vicryl or PDS is often chosen. Its strength loss should ideally match the wound gaining its own strength.
And when do you absolutely need non-absorbable?
When you need permanent strength or support for tissues under significant long-term tension. Things like bone anchors, ligament or tendon repairs, vascular anastomosis sometimes.
So match the absorption profile to the healing curve. What about the size, the caliber?
Caliber is dictated purely by the strength needed. The rule is simple. Use the smallest caliber suture that will reliably hold the tissue together.
Why the smallest?
Less foreign material, less tissue trauma from the needle and suture passage. Don't use a bigger suture than you need.
How does the specific tissue type guide suture and needle choice? General rules.
Okay, some general guidelines. For tough tissues under tension like fascia, tendon, maybe cartilage, you'd often use a permanent or long-lasting absorbable suture on a taper needle.
And for softer layers.
For subcutaneous tissue, dermis, skin, you're often looking at absorbable sutures, maybe on a cutting needle, particularly reverse cutting for the skin itself.
What if the wound is contaminated or already infected?
Big consideration. In contaminated or infected wounds, the go-to is almost always a monofilament suture.
Because of the lower bacterial adherence.
Exactly. Less risk compared to braided multifilaments. Also remember that infection itself can actually speed up the breakdown of absorbable sutures, reducing their effective strength duration.
Patient factors. Do they change the plan?
They can, yeah. Patient reliability for follow-up, their age, any conditions affecting healing. These might influence how long you need that suture support.
Any other tips?
One small thing. In very thin patients, if you're burying knots with absorbable suture, sometimes a braided one, tied carefully, might feel less prominent under the skin than a stiff monofilament knot.
Good point. What about the tiny sutures used in microsurgery?
Microsutures, yeah.
Hmm.
Selection there is mostly about matching the suture size to the vessel or nerve diameter.
Hmm.
You're talking 8-0, 9-0, 10-0, even 11-0 for the tiniest structures.
Are they different materials?
They're typically monofilaments, usually synthetic like nylon or polypropylene. Tying characteristics and memory are still relevant, just on a much finer scale.
Okay. A common aesthetic concern is the railroad track scar. What actually causes that appearance?
Right, railroad tracks. It's actually two potential issues combined. You get those little punctate dots along the incision.
The ties of the track.
Exactly. Those happen if skin sutures are left in too long. Skin actually starts to grow down along the suture tract epithelialization. When you remove the suture, you're left with a tiny scar dot.
And the parallel lines. The rails.
That's usually from tying the external skin sutures too tightly. The pressure causes ischemia, bit of tissue necrosis right under the suture loop, leaving those parallel marks.
So prevention is key. How?
Two things. Remove skin sutures promptly, usually within 5-7 days on the face, maybe a bit longer elsewhere. And second, don't tie skin sutures tightly. They should just gently approximate the edges, not strangulate them.
Are there sutures that absorb fast enough to avoid the punctate marks in skin?
Only the really fast-absorbing ones, like plain gut or vicryl rapide, they might dissolve before those epithelial tracts fully form. But the crucial thing is avoiding skin closure under tension in the first place.
How do you manage tension then?
Use deep sutures. Approximate the deeper layers, the dermis, subcutaneous tissue, to take the tension off the skin. The final skin layer should just be gently brought together.
Makes sense. Briefly, any alternatives to sutures we should mention?
Sure. Stainless steel staples are very quick, very non-reactive, but the approximation of the skin edges isn't as precise. They cause the least ischemia, though.
And skin glue.
Cyanoacrylate adhesives, yeah. Great for very low-tension wounds that are already perfectly aligned, very fast. But they don't provide much tensile strength and can sometimes cause blistering. Approximation can be imprecise, too.
Okay, let's wrap up. What are the absolute must-remember takeaways for residents heading into exams?
All right, key points. Monofilament sutures for contaminated wounds. Use permanent sutures for significant long-term tension needs. Match absorbable suture strength loss to the wound's healing timeline.
And for skin.
For skin closure, consider fast-absorbing options like gut or vicryl rapide if leaving them in. Otherwise, remove non-absorbables promptly. Always use deep sutures to relieve tension on the skin edges to minimize those railroad track scars. Avoid tight skin sutures.
Excellent summary. That's incredibly valuable knowledge, not just for exams, but for daily practice. Thanks for breaking it down.
My pleasure.
So as you continue reviewing, really think about why you'd choose one suture over another in different situations. Consider the tissue, the tension, the contamination risk. How do the properties we discussed fit that specific challenge? Until our next deep dive.